Good afternoon. Welcome to Grand Rounds today. I have the pleasure today of actually reintroducing Dr. Kasey Strosahl. Dr. Strosahl is a board-certified psychiatrist. She is the director of the behavioral health unit here at Mary Greeley, and she's also an adjunct assistant professor of behavioral medicine at Des Moines University. She kindly has accepted our invitation today to review with us medications and restraints for agitated patients, and please join me in virtually welcoming Dr. Kasey Strosahl.
All right, thank you, everyone. So, as Dr. Hallberg mentioned, we'll be talking about medications and restraints for agitated patients. And starting with my disclosures, I have really nothing to disclose except for every day of my career is dealing with people who are not having their emotionally or behaviorally best day, and I really love it. So why is that? Because it's a huge opportunity to help them through many means to improve their state of being. What I want to do to start is to preface that there is not a lot of research on best practices in agitation. And you can imagine, I show up to a room on the medical floor, the patient's agitated and yelling, screaming, hitting at the nurses. Am I going to be able to get that person to sign an informed consent before I enroll them in a research study? No. So that is why there's not a lot of information on this. So going through the presentation, we're going to go through some background information, definitions. The first step would be communication and de-escalation of agitation, and then moving on to medications and, if we have to, restraints. Okay, so definitions. Some of these terms are pretty broad, and so we'll start here with aggression. According to Levinson, aggression is a hostile, threatening, or violent action directed at a person or object, sometimes with no or trivial provocation. According to Harwood, it is hostile behavior or threat of attack. So this is very similar but different to violence, which is an overtly aggressive action directed at a person or object, or the use of physical force, verbal abuse, or threatening or intimidation, which can result in harm, hurt, or injury to another person. Agitation is more of a broad term, which is just a state of pathologically intense emotional arousal and motor restlessness. This is one of the reasons why I hate documentation of just agitation. It's because it doesn't mean a lot to me. It just means that the person is not doing well. And then we've all been irritable. So irritability is a state of abnormally low tolerance in which the individual is easily provoked to anger and hostility. So what does the agitated patient look like? This guy. So the most likely perpetrator to be an agitated patient is a man that's 75 to 95 years old. The female counterparts of the same age are not far behind that, and what's to account for that is dementia and delirium. The violent patient, on the other hand, is more likely to be a male younger than 35 years old. And who is the victim of this agitated patient? You guessed it, the female nurse. They are the most likely to be the victim of this. Healthcare workers are considerably higher risk for workplace violence than other professions, approximately 5 times more likely than the average U.S. worker to be the victim. In 2016, healthcare workers made up of 60% of all reported workplace violent injuries, according to the Bureau of Labor and Statistics. So again, I said nurses are more likely to be the victim than physicians, but mental health professionals are about 3 times more likely than just a medical nurse to be the victim of this. Aggression. So there are several different types of aggression that we'll go through, and they're actually quite different in the approach to how to de-escalate those. So instrumental aggression, we have all met this person that they have used some sort of threat or aggression in the past. They've found that it gets the job done, and so they then start using threats or violence to get their way in the future. They're not doing this because they're emotional about it. They're just doing it because they know they can get what they want. So to de-escalate these folks, you want to use some counter offers to their threats. For example, if they say, I'm going to hurt you if I don't get a cigarette, you might just say, I don't think that's a good idea. And if they banter back, just making them, let them know, let's not find out what will happen, versus giving them specifics of what you might do if they act out. Fear-driven aggression. So this isn't self-defense at all. This is that someone wants to avoid being hurt, and they may attack to prevent from getting hurt in the first place. So to de-escalate them, you want to give them plenty of space. You don't want to use that show of force or intimidation, because that's only going to make them think that they will be hurt and will further cause them to act out. So reassuring them and slowing their pace is really what's most necessary. So if they're constantly repeating, don't touch me, you want to give them a bit of space and then repeat back to them, I'm not going to touch you, I'm not going to touch you. Let's just give ourselves some space. Just slowing that down, matching how many times they say something actually can be very helpful, because it reiterates to them their thinking pattern as well. And then there's irritable aggression. There are two forms of irritable aggression. One of those is that they've already had their boundaries violated. They want to be heard and they want to be validated. You know that this is what they're dealing with, because they are telling you why they're angry. So you want to set some conditions for them to be heard. And then there's the irritable aggression, that they're just chronically angry at the world and they're looking for any excuse to get angry. Generally, they make unrealistic and erratic demands. They often get enjoyment out of creating fear and confusion. So you want to give choices, and you want to give them emotionlessly, because you don't want to give them the satisfaction in providing that emotional response that they want. So aggression really is just an indication of the patient's level of distress. So they are attempting to get their needs met, just like the rest of us want our needs met, but all of their coping abilities have been exceeded. We see people all the time with lots of good coping skills, and we also see people that have virtually no coping abilities, and so this aggression can be one of their coping mechanisms. So people that are higher risk to be aggressive or violent are those with a cognitive impairment, those with mental health problems, if there's drug or alcohol misuse, or if there's a history of crime or aggression. And even further, so conditions that are associated with agitation or aggression are delirium. I would say delirium is often subtle and easily overlooked on the medical units. They generally have an altered level of awareness. They have problems directing, focusing, and sustaining their attention. They're confused. They tend to have some perseverative behaviors, can have visual hallucinations, and there's often language and cognitive impairments. Other chronic cognitive impairments are intellectual disability, which is further down on the list, traumatic brain injuries, and dementia. Other indications are psychosis, personality disorders, most likely cluster B personality. We're talking borderline or antisocial personality, grief, anxiety, frustration with the situation that they're in, or unpleasant symptoms, just such as uncontrolled pain. So one of the ways that you want to start to prevent some of these things is communication. Good communication is very important. Mary Greeley uses the AIDIT tool, and many of these points are just part of that communication. To introduce yourself and what you're doing. That's the first thing I do when I walk into a new patient's room, is to tell them the purpose of why we are meeting. You want to be friendly, polite, respectful. Keep your language simple, because patients often do not have the same educational background that you do. And to check to make sure that they understand. I think there's a statistic that someone, if they are not fully clothed, remembers maybe at most a tenth of what you tell them. Attempt to be on the same physical level as the patient. Most providers like to come in, stand over the patient, hover above them, and leave as soon as possible. I always try to sit down in the room with them, take a seat, be on the same level. They will actually feel like you spent more time with them if you're sitting on the same level as them. They also feel more understood and heard. You want to use non-threatening tone and body language. Don't stand with your hands on your hips and bark at them. You also want to validate how they're feeling and make the family your ally. The family will know possibly what makes them angry or what sets them off, and how that way you can try to prevent that from happening in the first place. So moving on to de-escalation. So if possible, remove the provocation. Provocation may be anything. It could be any lines if they're not necessary. You could try and remove those. It could be you, though. Often the providers are the provocation. You want to give the patient some physical and emotional space. Stay calm and friendly. Ask what you could do to help. Often there are some needs or concessions that could be given, even if it's not the major, even if there's not something that you can give them, maybe there's something else that they would appreciate. Acknowledge their distress without accusing them, and don't make threats, don't get angry, and always respond in a calm and measured way. I think we can liken what our behavior should be if we think about having a substitute teacher back in school. The substitute teacher that was always overly friendly and kids got away with a lot was not the substitute teacher that you wanted, because the room was quite unruly, whereas substitute teachers who were very demanding and yelled at everyone was also not the way you wanted to go. It's someone that is confident and calm, and they are able to command your attention and get the most respect from you. So don't forget to use your judgment. Balance all of the risks involved. Always make sure you have an escape route that is clear. Ask for additional support when needed, and know when to disengage or remove yourself from a situation. There have been times where I've had someone ask me to leave the room. I could try to redirect the conversation to see if I was able to remain in the room for a period of time for further evaluation. But as soon as someone asks me the second time, or if they're starting to escalate, I leave, because there's not a lot of information that you're going to get from someone once they start to escalate like that. So when verbal interventions fail, then we come to medications. So the aim here is for therapeutic intent. It is not for sedation. So we're looking to treat what is causing them to be agitated, or what may be precipitating this. Calm is a secondary benefit. That is not the initial intent, though. An example of this, I had a patient transferred from an outside hospital this past weekend who was given a lot of medications in less than 24 hours. And at one point, the patient was given about 7 milligrams of midazolam over a 45-minute period. Another injection included 5 milligrams of lorazepam. So those were not for therapeutic intent. Those were for sedation. They were trying to knock the patient out. Medication routes, there are lots of them. Oral includes tablets, liquid, or my favorite, which is fast-dissolving tablets. Intramuscular and intravenous. The patient should always be involved, if possible, in the choice of medications. You'd be surprised that many people do request an intramuscular injection if they're really worked up, and the oral medications are going to be slower, but involving them in that process, oral would be preferred, but they are slower onset. So what we're going to talk about principally are 3 different medications, which are Haldol, haloperidol, olanzapine, and lorazepam. The exact choice of medications, there's pretty poor empirical evidence behind them, but These medications can all be used because if you're using them, there's usually a concern for the life or health of the patient or someone else, and you can treat without consent if needed in those situations. One thing that's not on this list that's of utmost importance is don't forget the importance of nicotine replacement. If you wake up in nicotine withdrawal and you're already irritable, it's not going to take much to get to aggressive or violent. We'll go over haloperidol most here because it does have minimal effects on vitals. There's negligible anticholinergic activity. There are minimal interactions with other non-psychiatric medications, and it is the safest option in alcohol-intoxicated patients. The risks of Haldol are that it does have a propensity to lengthen the QTC intervals, causing torsades. This is most significant if there are already cardiac issues and if you're giving it IV. So if they already are on something like Zofran or ondansetron, if they have a congenital long QTC, if there are electrolyte abnormalities such as hypokalemia or hypomagnesemia or uncontrolled hypothyroidism. And the IV dosing should be limited to 5 to 10 milligrams per day with Haldol. And then you would also need to use telemetry monitoring. I know agitated patients don't always keep their telemetry monitor on, so you'd still want to try to do intermittent EKGs. Some more risks are of extrapyramidal side effects, being dystonia, tremor, muscle stiffness, and high doses can also cause catatonic reactions due to excessive central dopamine blockade. We won't talk as much about it, but olanzapine is my favorite. There are reduced risk of near-term side effects, being dystonia or akathisia, and it's also more calming than haloperidol, and that's one of the reasons I like it. It is more expensive than haloperidol, but it certainly works very well, and it is a more potent antipsychotic than haloperidol is. So there are a lot of factors that we need to consider when we're choosing which medication to use. Those include if we suspect that there's a delirium component, if they're in withdrawal, if they're intoxicated with a substance or medication, or if they're psychotic. So this is a fairly nice protocol that was in the Psychopharmacology of Agitation consensus statement for emergency psychiatry. The problem that we run into is that we need very specific dosing based upon the level of agitation and the age of the patient. So this wasn't going to work for our purposes. So I did work with Jessica Carter, and based on that previous slide, some current practices within our hospital and then levels of agitation, we were able to create this agitation algorithm. So this is to be used when non-pharmacological interventions have failed, meaning that if you decrease their stimulation, if you place them on a one-to-one sitter, and you're already kind of treating what you believe is going on with them, these are some considerations. So first we're going to go over to the blue area on the left, which is the agitation associated with delirium. So then that's broken down further. So delirium is not all-encompassing. So delirium can happen if you're suspecting withdrawal or if you do not suspect withdrawal. So we're going to go through the withdrawal not suspected first, and that would be the first two columns. So the column on the left is for elderly or frail patients, and the column on the right is for adult patients. And we have three options on this part of the algorithm. The first option is oral medications, and as we mentioned, if we can get an oral medication in the patient, it's the easiest route. The first box is mild to moderate agitation. So if we look at the elderly patient, that would include olanzapine disintegrating tablet, because that will absorb into their system faster, 2.5 milligrams, or, not to be confused with or Haldol 1 milligram And then you could repeat either of those in an hour. You cannot keep repeating them necessarily every hour, though. If you repeat something several times and it's not working, you want to try and move on to something different. Severe agitation in the same elderly or frail patient, you'd want to use 5 milligrams of olanzapine or 2 milligrams of haloperidol. So those doses are approximately doubled for an adult patient. And then in option 2, this would be intramuscular injection. So if they're unwilling or unable to take oral medications, for an elderly patient, you'd want to administer 5 milligrams of olanzapine, and then you could repeat that in an hour. One thing to keep in mind is that if the patient has had parenteral benzodiazepines, so if they've had IV or IM benzodiazepines, you should not be giving olanzapine on the floor if you're not going to monitor their airway due to the respiratory depression you may have. If they are being closely monitored in the ICU, it's something that could be considered if needed. And then moving on to option 3, which would be IV medications, you'll see that olanzapine is not on there. Olanzapine is something that maybe you could consider in the ICU setting. I would not recommend it anywhere else. So it's just haloperidol is on there if you need to use IV medications. Again, monitoring for the QTC prolongation. All right, so going back to our delirium suspected, we'll move on to the alcohol or benzodiazepine withdrawal is suspected. And here you'll see we just have lorazepam. So if we're suspecting that someone's withdrawing, we're going to give them lorazepam because you're wanting to replace what was causing their withdrawal delirium. If it's mild to moderate, you're going to start with 1 milligram. And then if it's severe, you can do 2 milligrams. Now, if we're moving on to option 2, IV or IM, it doesn't really matter whether it's IV or IM because IV lorazepam is safe. It's equally as effective. If they have IV access, it's easier just to do it IV. All right, so going back here, since we just talked about alcohol and benzo withdrawal, we will move on to the right side of the table where we are looking at intoxication. So we want to see whether the patient is under the influence of a CNS stimulant or CNS depressant. CNS stimulant would be like the gentleman that I saw this week that overdosed on a 8-ball of meth, which is 3.5 grams of meth. He was tachycardic, hypertensive, flushed, and sweating and severely agitated. What he needed was lorazepam. So you need something to settle him down. You don't need to add any antipsychotics to him because he is already at risk for seizures, and antipsychotics can increase the risk for seizures. And so you want to just give copious lorazepam. Whereas someone that's intoxicated with a CNS depressant, such as alcohol, someone that's drunk with an alcohol level of around 400 does not need lorazepam because they are not in withdrawal. They need Haldol. So haloperidol is the medication of choice. Oral, 2 milligrams for mild to moderate agitation, 5 milligrams for severe agitation, and then again, IM haloperidol as well. Often these are in the emergency department, so often IV access has not been established. All right, now we're going to move to our red column, which is the agitation associated with a known psychiatric disorder. So if you know the patient has a history of bipolar disorder or schizophrenia, and they come in and they are agitated, if they're psychotic, we have several options to use. Again, my favorite is olanzapine, but there are other options including haloperidol with benztropine. So you'll notice that benztropine wasn't listed for delirium, and that is because the benztropine is anticholinergic and it could make the delirium worse. Versus someone with a psychotic disorder, we want to prevent from any extrapyramidal side effects. So we're going to use olanzapine 5 milligrams, haloperidol 5, and benztropine 1 milligram, or haloperidol 5, and lorazepam 1 milligram, and benztropine 1 milligram for mild to moderate agitation, or moving to more severe agitation, olanzapine 10 milligrams, or haloperidol 10 milligrams, and lorazepam 2 milligrams, and benztropine 1 milligram. There are also intramuscular options if oral is not given. So now we're moving on to the green section, which is if we do not know what's going on. So you're the person on call, you have this person that's agitated, they're not in the hospital for an infection, we don't know them to be intoxicated with a high alcohol level. So we're going to look to see, first, are they psychotic? So are they paranoid? Are they reporting that they're hearing voices? Are they making outlandish statements? If so, we're going to go with the right column where the psychosis is evident, which is identical to the red column that we had talked about where we're treating agitation with a known psychotic disorder. If there's no psychosis and this isn't looking like delirium, we're going to treat them with lorazepam. And that is in 1 or 2 milligram increments. So this has been made into a poster, and it will be available on the medical units. We also had it printed up into a handout form, and I will be placing a stack of these in the doctor's lounge for reference. If there's any questions or if you want an electronic version, feel free to email me and I can send that to you as well. It is a big sheet of paper, though. So if all of the medications fail, we always have seclusion and restraint. It's not our favorite option, and we'll go over that on the next slide. So seclusion is any involuntary confinement of a patient alone in a room or an area from which they're being physically prevented from leaving. So, putting a chair under the door handle is still seclusion, even if you're not locking the door. It's used for violent or self-destructive behavior. And restraint is any method that immobilizes or reduces the ability of the patient to move parts of their body freely. So medication is a restraint. It's called a chemical restraint when it's used as a restriction to manage the patient's behavior or movement and is not standard treatment or dosage for the patient's condition. So in the algorithm that we talked about, those are all standard dosages and standard treatments for the conditions listed. So you don't have to worry necessarily that those are a chemical restraint because they are treating the underlying condition. Whereas if the patient I got this weekend, if you're giving the patient 5 to 10 milligrams of lorazepam or midazolam, that is a chemical restraint because it's not treating their underlying condition. So why do we not like restraints? Restraints can cause injuries both to staff and to the patient. It's both physical and psychological injuries, and as many as 2/3 of the staff injuries are injuries involving psychiatric patients occur during containment procedures. So it's not without risk that the patient needs to be restrained. And it's also detrimental to the patient-physician relationship. So 2 types of restraints in our Mary Greeley order set. One is medical. This is to prevent someone from pulling their tube out, to pulling IV lines. And that order is good for up to 24 hours and must be renewed after 24 hours if needed. Whereas violent restraints are for violent things. And the order length is dependent upon age. For adults, that would be 4 hours. They are renewable if needed. For the smallest of people, little kids, that order is only for an hour. So what are the different types of violent restraints? Those are physical hold, soft limb restraints, 4-point restraints, chemical restraints, restraint chair, restraint wrap. So physical hold, let's say that you are going to give the patient an intramuscular injection. They don't necessarily want an intramuscular injection, and you hold them down to do it. That's a physical hold, and it's a restraint. So it may not last for very long. It may last for a minute, but it's still a restraint. or if someone needs to be moved to a different area and you have your hands on them to move them, that is a physical hold and it is a restraint. So here's some etiquette and rules. I'm not going to say it's etiquette because it's the nice thing to do, it's the must thing to do. The order must be placed within 15 minutes of the restraint. So it has to be back timed to the start of the restraint. So when this happened, so if the first thing is that you're laying hands on the patient, that's the start of the restraint. And then the face-to-face assessment must be completed within an hour of that first initial time. And that must be after the time that the patient restraint was started. So at 12:40, we start holding a patient down. I can't do the face-to-face assessment at 12:40. If I go back at 12:45, when all is said and done, the patient's still in restraints, that would be an appropriate time to do it. But anywhere up to an hour after the restraint is started. And then you must document all types of restraints that were used. So this is the Mary Greeley order for violent restraints or seclusion for adult patients. You'll see that there is a reason for the restraint or seclusion, and then the different types of restraints or seclusion, and you have to mark everything that was used. There's a box for the time of the face-to-face evaluation, and then you have to justify the restraint or seclusion. You need to say what was going on, what's going wrong with them. So if you know they have delirium and it's agitation associated with delirium, they're really confused, that's something that needs to be indicated, because that will also indicate other interventions in the future. When this face-to-face is done, this is the provider order, by the way, this is not the nursing order. There's a box at the bottom whether the restraint or seclusion needs to be continued. If the patient was in restraint or seclusion beyond the time when you did the face-to-face, the answer should be yes, because they were still in it. If it's discontinued, 15 minutes after you did the face-to-face, that's fine. But the time that you're doing this order in the face-to-face, that's when the order can be discontinued. All right, so there's some resources that were used, and I ran through those algorithms pretty quickly, but are there questions about any of the algorithm or anything else? So there's a question: can a rational patient legally request physical restraint? So we have had that topic on our unit. So there have been patients with borderline personality disorder with strong self-harm urges where they themselves cannot physically prevent themselves from harming themselves. And we have needed to use a restraint. In our case, it was the restraint chair for a period of time until they were able to process and calm down. So this is a situation where I would say that a patient has requested physical restraint. They asked to be put in restraints to help them not harm themselves in the process. So I would say that there are situations, but there are probably not many situations where someone is going to request physical restraint. Any other questions? Again, we've seen a lot of situations where either there's too little treatment as far as medications done to treat a combative patient, where a code has been called. I've the pharmacy would be able to tell you everything they've seen, but I know melatonin has been ordered in combative patient situations during a code. That's not even that effective for sleep, so I would say it's not appropriate in a code situation. And we've also seen quite the opposite, where too much medication is used. And then regarding some restraint orders over the weekend, there was a patient who had some IM Haldol while intoxicated in the emergency department. And the patient was given 5 milligrams of haloperidol, and good for them of thinking that they were possibly giving a restraint, but they did not need an order for a chemical restraint for 5 milligrams of haldol in a very physically fit adult young male patient. But we just need to think logically about what we're doing and all of the restraints that could be used. So Julie asked if nurses can enter violent restraint orders. So nurses can enter both violent and non-violent restraint orders. There are nursing orders for both. On the medical side of things, there is a separate physician order because the physician has to do the face-to-face assessment, and that face-to-face assessment information is in the physician order. So there are two separate orders, one for nurses, and they can put that in after they've gotten the okay from the provider within that 15 minutes of the patient entering into restraints. But then the physician should put in the face-to-face assessment, which is built into that physician order itself. Julie also asked, how often should we do EKGs for patients with multiple Haldol doses? I would say it's, if you are doing IV Haldol, if you have an EKG before you've given them any medication and they were, below 400 milliseconds, you probably don't need one after your first dose. But if you are giving, that 5 or 10 milligrams of IV Haldol, you definitely need EKGs. And also you have to weigh in how agitated is the patient and can you get the EKG. But it's not necessarily after a specific number of doses. If they're at risk for prolonging their QTC, then you would want to get it sooner than someone that their QTC before this happened was quite low. All right, so like I said, I will have these handouts, some of them in the physician lounge, feel free to grab one or send me an email, Strosahl at MGMC, for an electronic copy. There will be versions on the medical units and I assume the emergency department as well. All right, thank you.